You're listening to the Good Question Podcast with Richard Jacobs. Our goal is to make each of our guests exclaim, that's a good question. I don't know the answer. Because when that happens, it means you, the listener, may be inspired to learn more beyond the interview and to ask great questions yourself that lead to new insights. In this podcast, we cover historical and current anthropology, comparative religion, and history. Welcome, and let's get started.
Hello, this is Richard Jacobs with the Good Question Podcast. My guest today is Matthew M. Kurtz. We're going to talk about the identification and treatment of neuropsychological defects, deficits in schizophrenia and cognition in general. I think it's going to be a very interesting call in dealing with various mental illnesses. So welcome, Matt. Thanks for coming.
Yeah, my pleasure. It's great to be here.
Yeah, if you would, just tell listeners a bit about your background and, how you came to study these effects.
Yeah, so I started out as a experimental psychologist. I was basically studying learning processes in rats in the psychology department. And for a postdoctoral fellowship, I went through an interview and got a job offer as a postdoctoral fellow at the University of Pennsylvania, where they were focusing their efforts on sort of understanding the neural basis of schizophrenia. And it was during this 3-year training period that I really got involved in doing schizophrenia research. And I was able to apply sort of the learning principles and the scientific principles that I'd learned as a learning-based psychologist at Princeton, but was able to take this and start applying this to schizophrenia and the cognitive difficulties that people with schizophrenia frequently have. So I got involved in that work at University of Pennsylvania, then went on to the Institute of Living, a psychiatric hospital in Hartford, Connecticut, where I developed a program in collaboration with colleagues treating these cognitive difficulties that people with schizophrenia frequently have. And then I've continued that work at Wesleyan University here in Middletown, Connecticut.
Okay, so what have you discovered about schizophrenia that maybe isn't commonly known? Any of the effects or the parts of the body or that are involved that maybe people don't know that are normally involved? Like what's unique about what you've figured out so far in your studies?
Yeah, so, for many, many years, schizophrenia has been diagnosed based on a pattern of symptoms. And these symptoms have typically included delusions, sort of believing things that are untrue, manifestly untrue, hallucinations, which are typically auditory in nature, where people hear things that other people don't hear. And the diagnosis is made on this basis. And so for many years, the disorder was really thought of as a disorder of sort of these problems in thinking, these sort of disruptions in sort of rational thought processes. And what we've been working on really for over 20 years now is trying to understand that along with these psychiatric symptoms, and again, these are the symptoms on which clients are actually diagnosed, that along with this, there are real persistent and pretty significant difficulties for many people with schizophrenia in their ability to pay attention, in their ability to remember things, in their ability to problem solve, to sort of think of sort of conceptualize problems and come up with a series of steps to solve that problem. There are difficulties also in language, in finding words and naming. And so our work is really focused on better understanding these difficulties in cognition. We call all of these skills sort of skills in cognition, trying to understand them more effectively, and then developing treatment programs to try and elevate these skills in people with schizophrenia.
What kind of cognitive issues have you seen? Like disordered thinking, or people just literally can't think? Like what happens to them?
Yeah, so you've got these psychiatric symptoms where people may be delusional. They believe perhaps the CIA is after them. They have perhaps hallucinations where they believe that an important person is talking to them. Some people believe that God is speaking to them directly. And these are the symptoms of the disease. What we've observed, though, in our work is that despite these symptoms, it's often difficulties in remembering things that people say to them, remembering things that they have to do in a work situation or in a social situation, the ability to concentrate and pay attention to what people are saying, the ability to solve problems in their everyday life. It's these skills that are actually more closely linked to their day-to-day functioning than are those symptoms of delusions and hallucinations. So I think a lot of people think, someone is hearing voices. That's what's sort of impairing their ability to function in their day-to-day life. And what our findings have really shown is that these symptoms may have some relationship to functioning, but it's actually the difficulties in cognition, in being able to pay attention, being able to concentrate, being able to speak in a sort of coherent, cohesive manner that are really the stumbling blocks from sort of progressing functionally, developing more friendships, getting back to work, being more successful at work. And so it's those cognitive difficulties rather than the psychiatric symptoms which seem to be playing a larger role.
Well, why do these cognitive symptoms happen? Does anyone understand the underlying biology and what causes people to have cognitive difficulties and schizophrenia? And is it always there, or does it coincide with them, quote unquote, having an episode?
Yeah, so that's a great question. To answer the second part first, they are there independently of the episode. So the disease, in terms of its symptoms, tends to oscillate, but the cognitive difficulties are actually present during those oscillations. So when the client is stabilized, having very few symptoms, you will see the same level of cognitive deficit typically that you'll see as the client becomes more symptomatic, more delusional, having more hallucinations, that type of thing. So the deficits are clearly enduring and somewhat independent of the symptom presentation. The source of these deficits, there are a number of potential sources. We do know that people with schizophrenia, when looking on a group basis, so in groups of people with schizophrenia, that they have several brain abnormalities. One of these brain abnormalities, and probably the most powerful finding, is the finding of enlarged ventricles. And ventricles are sort of the spaces at the center of our brain. They're sort of holes, actually, at the center of our brain that contain a fluid that circulates around the brain, bathes our brain, and provides some sort of structural protection for the brain. And so those spaces that are at the center of our heads, or part of our brain structure, are enlarged in people with schizophrenia, suggesting that there's been some loss of brain tissue. So that probably is one contributor to the cognitive difficulties. We know that first-degree relatives of people with schizophrenia, so if someone is a first-degree relative, a brother, a mother, father, that they, on average, will have cognitive deficits as well, although the cognitive deficits will be much more modest than what the patient has. So if you have a first-degree family member who does not have the illness, and they go through a battery of cognitive tests assessing memory, attention, problem solving, they'll show on a group basis a pattern of difficulties that is quite similar to their siblings or children who have the disorder, but just at a much more modest level.
Why? How could that be possible?
Yeah, so it's a great question. I mean, so the idea of there being first-degree relatives who have these more modest deficits is the idea that they may be carrying some of the genetic load of schizophrenia, even though they may not be carrying a sufficient genetic load to have the disease express itself. So that's been the thought.
Is there a genetic basis for schizophrenia? Has that been observed?
Yes, that has definitely been observed. So there is no doubt that if you have a first-degree relative with the disorder, your chances of developing the disorder are raised by roughly 10 times. That's pretty clear. And the numbers decrease as the distance increases in terms of how close you are as a blood relation. So there's clearly a genetic disorder. There's a genetic basis. We also know that in identical twins, right, twins that share genetic material, when one of the twins has schizophrenia, there is a 50% chance that the other twin will develop schizophrenia as well. And this is sort of an interesting statistic because it both suggests that there's a genetic element, but it also suggests that this is completely genetic. If two people have the identical, genome, one would expect that both would develop.
Well, no, you have epigenetics. You wouldn't expect that at all.
Exactly. Yeah.
So what epigenetic marks seem to correlate with schizophrenia if you look at the underlying genome? Smoking, tremendous stress, heat shock, like what? This would tell me that schizophrenia may be latent in, let's say, a family, and certain things will happen to bring it out.
Yeah, so that's right. So they've typically been grouped into two sort of general categories. One of the categories are sort of stresses or perturbations that occur really early in development. So this is in utero, when there's some evidence suggesting that if people have the genetic predisposition, if the mother actually has a serious flu during pregnancy, there may be an elevated risk of that child subsequently developing the disorder as they get older after they're born. We also know there's actually been very interesting data taken from the Second World War. So in Holland, there was what was called the Hunger Winter during the Second World War, where the Nazis blockaded the food basically completely from the country. And people in Holland were just living on just really limited food sources. And during this period, the rates of people who were born during this period and subsequently developed schizophrenia were much, much higher than rates observed prior to the Hunger Winter and after the Hunger Winter. So clearly, the stress on the mother at select junctures can, in fact, increase the likelihood that a child born that already has the genetic predisposition will develop the illness. The other set of stressors, the second set of stressors that people are just starting to look at now, are stressors around actual interpersonal trauma. stressors around socioeconomic status, living in a lower socioeconomic status, stressors around being part of an immigrant group that is discriminated against. All of these factors seem to play a role in higher rates of people being diagnosed with schizophrenia. So really two sets of potential environmental influences leading to the emergence, both these stressors on the mother and then actual stressors on the person who ultimately develops the illness by way of interpersonal trauma, social trauma, that type of stressor.
I don't know. Are there any particular? Well, I've heard stories. I don't know if they're real, but people that seem to be okay, and then they went through a period of incredible stress. Like, my uncle supposedly he had schizophrenia, and he developed it, I guess, after being in the Navy and going through the boot camp and the stresses of all that. Is that a common story that you've heard? Something like that.
Yeah, it's interesting you bring it up because there's a lot of work that's been done on schizophrenia at VA hospitals because the VA hospitals tend to have, obviously ongoing relationships with people who've been in the military, and they have a lot of programs. They provide a lot of programs for people with psychosis. And so it's interesting. I would argue that it will probably be unlikely that the stress of just being in the military itself would have caused schizophrenia. But I think if someone has that genetic predisposition and you go through a stressor such as that, I mean, it depends on the nature of the military service, that certainly it could provide the setting in which the illness might emerge given the predisposition. There have been arguments that the folks that are studied at the VA actually are sort of a higher functioning group of people with schizophrenia because they're developing the schizophrenia often later than people who perhaps have a more severe form. If you're developing it in your 20s, for example, that often suggests that the form itself may be somewhat less severe.
Okay. In terms of age of onset, if it's trauma-induced, is there a certain set of age ranges where it happens versus, what do they call it? I guess cryptic, where it just comes about. There doesn't seem to be any correlating majorly stressful event.
Right. Sort of idiopathic, right?
Idiopathic.
So, yeah. So, it's an interesting question. I would clarify that I don't think there would be any trauma-generated cases of schizophrenia. That is, I think you would need some sort of genetic predisposition. But I get your point in terms of the trauma versus the idea that there's no obvious stressor. I don't know that there would necessarily be a difference in age of onset. I mean, I think that where we are now in terms of understanding the data is that these stressors play a role. I don't know that one set of stressors, may be more important at one stage of development versus another. That I don't know that we have a handle on research-wise.
Okay. So what particular research questions do you have about schizophrenia? What are you trying to do to advance the knowledge of it in particular?
Yeah, so our most important focus in the lab now is trying to understand programs of treatment. This is behavioral treatment, not medication treatment, that help elevate or improve cognitive skills in people with schizophrenia. So these interventions take a couple of different forms. We study an intervention that involves repeated practice on cognitive exercises on a computer screen. So we have people with schizophrenia come into a computer lab. They are administered a series of exercises focused on attention, memory, problem solving, where they repeatedly work on tasks that they're almost sort of like computer games, but they're targeted at improving skills in paying attention, in remembering items, in being able to pay attention to multiple items at the same time, sort of shifting attention or dual attention. And the idea is that through this repeated task practice, think of it as sort of a weight training for the brain, we're trying to elevate cognitive skills in such a way that allows these folks to improve their sort of everyday life function.
Okay. Like what? What can they do to help themselves? And can they only do it once they're stable on medication, or can they do it when they're I don't know what do you call it when someone is again in good shape versus they're having an active event, they're in the throes of having problems?
Yeah, it's a great question. So if someone is sort of in between events, they would be considered to be sort of psychiatrically stable, as you mentioned. That's exactly right. And then someone may be in the midst of symptoms, in which case you say that they are sort of in an exacerbation of the illness. And that's frequently when people get hospitalized, right? When they get placed in the hospital, and typically their medications are shifted at that time. So, and actually, Richard, can you remind me again the other part of that question?
Yeah, I was going to say, can interventions be effective when someone's at the peak of, being symptomatic, when they're really not doing well? Right. Or does the person have to be stable in order for them to, be helped?
Great question. Yeah. So we do require folks to be stable when they enter the protocol. And what that means is that they're taking their medication on a regular basis and they're not showing dramatic signs of the illness. Most of the clients in our protocols are, in fact, showing some symptoms, but they're typically in the mild range because the medications don't usually take away all the symptoms. It would be hard when someone is literally in the throes of illness where they are actively psychotic, they are delusional, hearing voices, for them to participate in the types of interventions that we're administering. I mean, they're typically involved, coming in as an outpatient, participating several times a week. The sessions often last for an hour to 2 hours. And so the ability to sort of engage in that type of activity when someone is floridly psychotic would be very difficult.
Okay. So what are some of the interventions that you come up with and, how do they work and how do they help?
Yeah. So I mentioned the one which involves basically a series of cognitive exercises. We use a program called PSS Cog Rehab. It was developed by Odie Bracey, a psychologist, and it basically involves a series of tasks. Some of them are quite simple. Some of them may be simply focusing on a computer screen and clicking whenever a yellow box comes on the screen. It sounds very simple, but for someone who has pretty significant sort of baseline symptoms, even in the presence of good antipsychotic treatment, it can be difficult to stare at a screen over a period of 5 to 10 minutes and click on a yellow square that can appear anywhere on the screen. In addition, we work with clients on the reaction time, how quickly they're responding. So that might be an example of one type of exercise. A different type of exercise, sort of a next step up, might be clicking on a yellow square that appears on the screen while inhibiting one's response to a blue square, not being sort of distracted by the onset of a blue square on the screen. And so those are some of the simpler exercises that for some of the folks who are at a lower level of functioning might find challenging. For other folks, they graduate from those exercises very quickly. They succeed on those exercises very quickly, and they move on to more complex exercises. I should say that in every case with these exercises, we start them at a level that the client can manage. So we very much titrate task difficulty. So we would start with a exposure time of the yellow square, for example, that would be sufficient that the person could do well on the task. And then we would gradually decrease the amount of time we present the yellow square for the client to respond to as a way of gradually titrating and increasing task difficulty in such a way that we're sort of engaging brain systems. And then ideally, the idea would be as the difficulty gets greater, that the neural systems would begin to get stronger with the practice in the higher difficulty levels. So that's sort of the general strategy.
What have you observed? Is that the case, or what happens with people?
Yeah, so we have actually found that people do tend to get better on the exercises. We've also found, even more importantly, that when we administer a battery of cognitive tests, and these are tests that are not directly trained in the cognitive remediation programs, that we do see improvements. Specifically in our own studies, we've seen improvement in working memory. And this is true even when we compare results to a very active control group. So we have a control group that actually is getting onto the computer for the same amount of time. They're learning skills in Microsoft Office, Microsoft Word, Microsoft PowerPoint. We find that, in fact, that even with that kind of structured, active intervention that folks are doing in the control conditions, people doing these carefully titrated cognitive exercises focused on attention, memory, and problem solving do appear to get better at their cognitive skills, even relative to such an active control.
Okay, so do people do these exercises forever? Do they do them once a month, once a quarter? What's the protocol and do they get better and stay better? Or will they slide back if they stop?
All great questions, Richard. So we're typically doing 2 to 3 times a week. So people are typically coming in 2 to 3 times a week, and they're doing this over a period of anywhere from 3 months to 6 months. A lot of times it depends on where the client is in terms of their treatment. As clients get better, they may want to start applying for jobs. They may want to engage in other pursuits. And so we certainly understand and respect that. But typically, we're shooting for a minimum of 3 months of treatment at the very least. In terms of durability, we've just started to evaluate that question. It's a question we don't have an answer to from our own lab. I can tell you, though, in the research literature that there have now been a variety of studies that have looked at durability over periods of roughly 3 to 6 months. And generally, the improvements in cognition that you see with these cognitive remediation programs do persist at a 3 to 6 month follow-up. And that's studies that include, meta-analyses that have looked at studies that include literally thousands of people with schizophrenia.
So, in your clinic, you say there's improvement. What does that mean? Does the person gain significant function or a little bit? What happens?
Yeah, so it's a great question. So we are seeing improvements on measures that we're not training in the cognitive protocol. That's where we see the improvement. The big question now is, to what degree does that improvement in cognition then transfer to everyday life skills, which you sort of alluded to in your question. And that's really still an open question. We know the cognitive remediation programs do, in fact, produce improvements in functioning, but the mechanism of that improvement is something we're still trying to sort of sort out. That is it contingent on that improvement in cognition that we're seeing? I think many people would think that, but that's still a question that's being explored. We know that folks in these cognitive remediation programs get better cognitively. We know across the literature that people in these cognitive remediation programs get better functionally. They get better with their activities of daily living. But what we don't know is the actual mechanism. Is it, in fact, the improvement in cognition that is leading to the improvement in functioning? That's something that's still being sorted out.
Okay. I mean, what's next in this? You have enough data on the programs to know that it works. So does everyone go through it? Are there different levels of it, depending on someone's impairment? Like, how is it, adjudicated or given to the person, and how are they analyzed to see what they need?
Yeah, so it's a great question. So your question really gets at that sort of research to clinic gap, right? The science to practice gap, which everybody sort of is aware of, and yet we're still running into roadblocks on how we get this work sort of out of the clinic, out of the academic clinic, and into general care for people with schizophrenia. So I would say now that it is still a fairly unusual thing to see cognitive remediation offered in a purely non-academic clinical setting. I think things are starting to change. I think there's been such a wealth of academic research that has suggested that these programs are effective, that you're beginning to see some uptake in clinics around the country and around the world, but that is still at a very early stage. So it's hard for me to answer, how does a person coming into a clinic sort of get triaged, and how do they decide whether they get the cognitive remediation? For how long do they get it? Given that it's still very rare to see these sort of academically based interventions be present in the general sort of group of clinics treating people with schizophrenia.
Okay. So, I mean, what is essentially, I guess, the next step? What's the next innovation or the next area you see that's needed to help these people?
Yeah, so I think there are a couple things. I think one really important area of development for the field is going to be developing interventions that are more powerful. So the interventions that we have now typically improve functioning or cognition at about, I would say, what we would call a third of a standard deviation. That would be the equivalent, right, of about maybe 5 points on an IQ test. Not insubstantial, 5 points. I think everyone would like an extra 5 points on their IQ, but at the same time, it's small. So we need to develop more powerful interventions that change cognition and functioning to even greater levels. We've already talked about another major issue in the field, and that is we need implementation scientists to really understand why is it that this broad array of clinics that are there in the community have been unable to sort of uptake this science that we've been doing in academic centers. That is, why have they not been able to implement cognitive remediation? Is it the cost of the computers? Is it a lack of training among the frontline clinicians? Are administrators not sufficiently knowledgeable about it? Or is it just simply a lack of funding, right? So these are all questions, open questions for the field, because it's really going to be important to get this out to patients. And I think another thing, another issue that the field confronts is the issue around making sure that it is accessible to all different types of clients. And we're still learning to what degree different types of clients benefit. And in some cases, this has to do with, for example, symptom patterns. Is it that people who have more hallucinations are more or less likely to benefit from the intervention? Are people who are older less likely to benefit from the intervention? These are things that we're still learning, and we still have to understand the predictors of a good treatment response.
Oh, how come we don't know yet?
Yeah, it's a good question.
Is it too new, or what's the reason?
It's still too new. So there have been some signals. I don't want to indicate no work has been done here. So there are some signals that younger clients do benefit more. We have seen that in some studies, particularly folks who are in the very early stages of the illness, soon after the onset. There's certainly some evidence of that. We do know that people tend to get better when there is a trained clinician doing the cognitive remediation. That is, there have been some programs where they set clients up in front of a computer and just have them do the exercises with little sort of background positive reinforcement, or a skilled clinician giving strategies. And we know that having a skilled clinician in the room does make a difference. And we do know that relating what the client is doing in the cognitive remediation to their everyday life really makes a big difference in the likelihood of clients to benefit. So there certainly are predictors of success. I don't want to suggest there aren't, but I still think we're in a learning phase there.
Okay. What have you learned in general from working with people that have schizophrenia about cognition? Has the work and their condition and their difficulties revealed anything to you about healthy brains or about other people?
Yeah, I think more than anything, it's how much we take for granted. So I remember one time listening to a talk from a very distinguished member of our field. And at the very end of the talk, he put up a New York City subway map and asked people to sort of look through the map and try and sort out the different lines and the different stops. And the fact that, if you're an experienced New Yorker, you can glance at that New York City subway map and pick out the line that you need and the stop that you need to get on and the stop that you need to get off. We do so many things so automatically with little thought. And the thing that I've learned is that there is a massive amount of sort of cognitive machinery, much of it, I think, occurring subconsciously, that is allowing us to so easily negotiate these very complicated cognitive environments in which we find ourselves. People with schizophrenia, unfortunately, that sort of machinery for processing complex cognitive environments is not always working at a top level. And so as a result, things that we take for granted, again, negotiating, maps, subway maps, road maps, utilizing advanced functions on computers, et cetera, that these things do not come automatically for people with schizophrenia. And there's a lot more training that is necessary for them to get up to speed in many cases, not in all cases, but in many cases.
Is there any current research that's promising that, you're looking to review that may help give you insights on what to do, how to make this even better?
Yeah. So, one thing that has been explored extensively in the field is whether there might be certain types of medication that sort of interact with specific neurotransmitter systems that might in some way enhance the effect of these cognitive remediation programs. Unfortunately, to date, these medications have not shown much effectiveness, but there are still ongoing trials and people are still actively pursuing new interventions and new avenues, and that potentially could be a real watershed area for the field. We just don't have the drug yet. So I think that's a really important area. Another area where we've actually seen, with a few exceptions, we've seen some really positive findings is combining exercise with cognitive remediation. So having people with schizophrenia actually exercise on a regular basis seems to do something to the theory is it's doing something with respect to blood flow to the brain that is allowing people to benefit more effectively from these cognitive training processes. So I think both of those avenues, new medications and this combination with exercise, and there's greater data now for the combination with exercise, are avenues to really improve the effectiveness of these cognitive remediation programs.
Okay. Well, very good. Where can people find out if there's a program like that near them? If they have a loved one or someone they know that could use it possibly. How do they get evaluated for it? How do they find it?
Yeah, it's great. So right now, as we talked about this gap between clinics and academic, settings, going to the local academic medical center website, wherever that may be, the nearest one, looking at the psychiatry department website, looking under schizophrenia services, probably be the best chance of being able to find a cognitive remediation program. Having said that, I hope that changes in the near future and that we start to see more of these programs in local community mental health centers.
Okay, well, very good. Well, thank you so much for coming on the podcast. I appreciate it.
Oh, yeah, it was my pleasure. It was good talking to you, Richard.
Thank you for listening to the Good Question Podcast. Please email support@thegoodquestionpodcast.com if you have any referrals to great guests for us to interview. Visit thegoodquestionpodcast.com to hear more interviews. And please help us spread the word by rating and reviewing us on Apple Podcasts, iTunes, Spotify, YouTube, or wherever you listen to this podcast.